Good morning. Today we're going to begin in chapter 12, which is diseases of the endocrine system. We're going to start, as always, by reviewing the anatomy and physiology of the endocrine system. So we'll begin on your PowerPoint on slide 5. Functions of the endocrine glands. The main function is that the endocrine system, the different glands that are located around or on the different organs are going to secrete hormones for the body to maintain homeostasis. So your major organs, you have your hypothalamus that controls your body temperature, your pituitary gland, your thyroid gland, parathyroid glands, pancreatic islets, adrenal glands, and then of course your testes and your ovaries. So those are your main organs that are going to contribute to your body's hormones, So hormones are chemicals that act on a target organ to increase or decrease the target's activity level. So for instance, in females, when the ovaries secrete the luteinizing hormone or the LH factor, what happens is that is usually when the LH factor, when there's basically a surge, an LH surge, the ovaries will be at the, it will produce an egg basically, and then when you have that LH surge, the luteinizing hormone, that's when the best time for pregnancy can happen during the month is when you have that LH surge. And so there's a lot of other examples, but that was just one that came to the top of my head. So the endocrine system, of course, if hormones are not active or they're too active, overactive, then it can definitely throw off the homeostasis of your body. Okay, we're going to go on to the types of glands. The two types of glands in the body, you have the exocrine glands and then of course your endocrine glands. So your exocrine glands are going to release the secretions into a duct and carries them outside of the body, like sweat glands will make you sweat and you get the perspiration on the outside of your body. And the endocrine glands are going to release hormones directly into the body and into the bloodstream. So this would be like the thyroid gland, okay, will secrete thyroxine and other types of hormones as well. And these are considered to be ductless glands, okay. So some of the glands that we have the 2 adrenal glands, we have 4 parathyroid glands, we have your pancreas, which is considered an endocrine gland, your pineal gland, your pituitary gland, 2 ovaries in the female, 2 testes in the male, a thymus gland, and a thyroid gland. And we're going to talk about each of those very rapidly. And let's start with, let's start with the pituitary gland. I've lost my page here, but we're going to start with pituitary gland anyway. This is sometimes called the master gland because it does control a lot of things that can happen in the body, and it's controlled by the hypothalamus, which, again, like I said earlier, maintains body temperature. So that is the pituitary gland. Keep on going. I already told you that if you have you can have overactive glands and you can have underactive glands. And when this happens, there's usually some kind of deficiency that can be fixed with medicine to help the situation. And then you can have a hypoactive or underactive gland as well. And again, there's usually medicine that can fix the issue. So if you look at table 12.1 in your text, this is a list of hormones. For each gland, you have FSH, the follicle stimulating hormone. This is going to be in the male and female. We usually just hear about the female, but this is going to stimulate the growth of eggs on the ovary, okay, and help it to mature basically, and it's going to secrete estradiol. In males, it's going to stimulate the epithelium of the seminiferous glands and cause sperm to basically produce. Spermatogenesis means producing sperm. It's the beginnings of producing sperm. Then we have luteinizing hormone, and when LH happens, when we have the LH surge, it's going to thicken the endometrium in females, and this is going to, like I said, be the best time for pregnancy. And then it causes like an increased progesterone. And then we have in the testes, it's going to stimulate the production of testosterone. Prolactin is the female mammary gland, so this is going to stimulate milk production after birth or shortly right before birth. Growth hormone, somatotrophin, there's several different growth hormones. So somatotrophin is going to increase the synthesis of protein in the body, and it's going to help, children mainly grow, their bones grow, and tissues grow. We have the ACTH, the adrenocorticotropic hormone. This is going to stimulate the production of corticosteroids, which will help with inflammation. It's going to increase your metabolism. The TSH, or thyroid stimulating hormone. This is from the thyroid gland, and of course it's going to produce the thyroid hormone. Then the posterior lobe of the pituitary gland. We have the ADH, or the anti-diuretic hormone, otherwise known as vasopressin. This is going to constrict blood vessels, so it's going to be able to lower blood pressure, increase blood pressure, and stimulate reabsorption of water from the kidneys, by the kidneys. Then the last part of hormones that we have just from the pituitary gland is the oxytocin, and this is comes from the uterus and the mammary glands, and it's going to stimulate the contraction of the uterus when you're about to have a baby, when you're in labor, and it's going to help actually secrete the milk that was formed by the prolactin earlier. And so those are just the hormones of the pituitary gland. So you can see this chapter has got a lot of information. So the pituitary gland is located underneath the side of the brain. It's very small, and it's divided into anterior lobe and a posterior lobe. And this is all controlled by the hypothalamus. Let me pause this for 1 second. Okay. Anyway, the anterior pituitary, we've already talked about this. I'm going to skip on past. Let's see. Okay, let's look at diseases of the pituitary, of the anterior pituitary. We have insufficiency, and then of course you can have hyperactivity of the pituitary, which is called hyperpituitarism. So an insufficiency in the anterior pituitary gland can cause dwarfism, and it's also called AGDH, which is adult growth hormone deficiency. And then an increase in the anterior pituitary gland is called hyperpituitarism, and this causes giantism, which is like an overgrowth basically, or another condition that's very similar, acromegaly. Okay, so if you have an insufficiency, it's going to cause you to be smaller, dwarfism. If you have a overgrowth of pituitary, it's going to cause giantism or acromegaly. Okay, so make sure you remember that. So with dwarfism, this is usually going to be something that starts with children. You're going to have, of course, inadequate growth hormone. They may be very smart, but they're just going to be very small in stature, and then they also may have an underdeveloped genitals as well. Let's see, we can do, keep going. If you have the other type of deficiency is very rare, but it's usually caused by damage to the pituitary gland. So adults are going to be more at risk for this, and then especially if they've had any kind of surgery on the pituitary gland, it can cause this, or any kind of tumor can cause this as well. Let's keep going to hyperpituitarism or giantism. This is the overgrowth of hormone, prior to puberty. Okay, so this is going to cause it's going to slow down the normal growth of bones as they join together, basically, especially in the skull. It's going to decrease your sexual development, and it's going to decrease your mental development in most cases. The cause of this is an adenoma or a tumor. And the treatment is the removal of the tumor and radiation to try to reduce the size of the tumor. And then if we have acromegaly, this is going to be usually when the long bones of the body, like the fibula and the tibia, are not going to have any kind of growth in them. You're going to have overgrowth of your soft tissues, like your ligaments and tendons and such. You may have an enlargement of the face with very coarse facial features, protrusion of the tongue, a curvature of the spine. And again, this is caused by an adenoma, and the same treatment is the same as the other. You can have radiation or surgery. Let's see. Let's go on to and talk about hormone supplements for these. We can have thyroxine, cortisone, growth hormone is one of the main ones we use. Sex hormones to compensate for the underdeveloped genitals and maybe the dysfunction sexually as well. The posterior pituitary gland is going to secrete oxytocin and vasopressin. So oxytocin is going to cause like the smooth muscle, the uterine muscles to contract, and then ADH causes prevents excessive water loss through the kidneys. Diabetes insipidus is one of the main posterior pituitary gland diseases, and this is a deficiency of the ADH. And so the water is basically not reabsorbed by the kidneys, and it gets lost in the urine. So patient with this is going to have extreme thirst, frequent urination or polydipsia, and excessive production of very clear urine or diluted urine. Let's see. With this as well, one of the main cautions that you have to look out for is dehydration, because if we have excessive urinary output, you can dehydrate very quickly. So the treatment is going to be to try to treat the underlying cause, which is a hormonal deficiency, and so that's what you're going to try to do to use like some kind of injection, nasal spray to supplement the hormones that are lost there. Okay, then going on to the thyroid gland is what we're going to start on next, and this is on page 311. The thyroid gland is like a butterfly shape, and it has a right and a left lobe. It's located on each side of the trachea or the larynx. We also have a cartilage that we have there, and especially in men, called the Adam's apple, just located right below the thyroid gland. Women can get this too, but they may usually have it removed. It produces thyroxine, also known as T4, when you do the blood work. It's also going to produce a hormone which is called the T3, which is the triiodothyronine, I believe is how you say that. But these are all produced in the thyroid gland, and they're produced from iodine. Thyroid gland is going to help regulate your metabolism. And let me see, we're going to try to get into more of the most important things here. The thyroid gland can also secrete what's called as calcitonin. When calcium is too much in the blood, it will secrete this calcitonin. So we don't have basically like an overproduction of calcium. Let's see. Thyroxine. Let's talk about that. Thyroxine, known as T3 again, stimulates the cellular metabolism by increasing the rate of oxygen used with subsequent energy and heat production. And so basically with thyroxine, nutrients that you intake are going to be converted into energy as part of your metabolism. Let's see. It gives you a lot of information on thyroxine. Let's talk about negative feedback failure. This constitutes one basis for a thyroid disease. The thyroid gland can be perfectly healthy, but if your iodine supply is deficient, then the gland's not going to produce that much needed thyroxine. And then of course you can always overstimulate the thyroid gland by having too much iodine in the body as well. The thyroid gland can be diseased with a increased iodine or decreased iodine, and then that's these can cause the diseases that are in your textbook that we're going to talk about. And the first one is hypothyroidism. So let's look at that. Hypothyroidism, you have maxedema is one of the first ones we're going to talk about, and this is severe hypothyroidism when thyroxine is not formed, basically. So the symptoms, you're going to have a bloated appearance, you can have a thick tongue, puffy eyelids, dry scaly skin, little perspiration or sweat, muscular weakness, sluggish, physical processes may be kind of sluggish, slurred speech, slow reflexes, and the list of symptoms and signs go on and on and on. The digestive system is going to be one of the main things that goes sluggishly with this condition. So you're going to see patients with constipation, frequent abdominal pain, weight gain, bloating. That's where the bloatingness comes from mainly. And it's going to increase the amount of lipids that are circulating in the body. So it's going to cause an increase of cholesterol and cause atherosclerosis, which is like a buildup of plaque in the arteries. Maxedema affects women a lot more than it does men, and it's usually around mid-age. Let's see. Let's look. Cretinism. This is the next one that we're going to talk about. Keep losing my spot. Cretinism. This is a congenital condition of the thyroid gland, and it's a deficiency. So the thyroxine is not produced like it should be here, and this is going to cause like a mental retardation, basically, of the patient. All right, because thyroxine is going to help your physical development and your mental development, and so if we're not producing enough, it will cause mental retardation, which is one of the main signs of cretinism. This usually happens during fetal development. Okay, if the thyroid gland doesn't I guess it doesn't form, or if it's just non-functional. And then if the mother suffers from like an iodine deficiency, it can also be passed on from mother to infant as well, or mother to fetus rather. Let's see, if we have somebody with cretinism, they're going to look very short. Dwarfism, they're going to have dwarfism. They're going to be very stocky looking. They'll have a protruding abdomen. Their sexual organs may not develop fully. The face is going to be misshapen. They're going to have a broad sunken nose and small eyes that are really far apart. They're going to have puffy eyelids and a short forehead. Then you're going to have a thick tongue as well. And the face is expressionless. So a lot of these you're going to see are going to look the same. It's all depending on what your blood work shows you. Let's see, a goiter. This happens pretty frequently. This is an enlargement of the thyroid gland, and it can be surgically removed, and sometimes it can be controlled medicinally as well. So this can be caused by a hypoactive thyroid gland, or it can be caused from a deficiency in iodine. Okay, and so that's what can cause a goiter. Some symptoms of a goiter. is usually a sign, actually. We're going to have like an enlargement of the neck, either right over here or right over here, and that will tell us usually if we have a goiter. And then, of course, our hormone levels will be off as well. So treatment, we're going to use some kind of iodine or iodized salt. We're going to use that. We can do surgery to remove it if we need to. And then if the goiter is excessively large, where it starts causing you difficulty in swallowing, then we can definitely do surgery and try to remove it. And sometimes I know physicians have done radiation treatment to reduce the size of the goiter. Let's see. Adenomatous or nodular goiters, this is another type, and this is when we excrete an excessive amount of thyroxine. And so the symptoms of this is going to be the same as a goiter, except we're going to have nervousness, tremors along with it, especially hands. Metabolism is going to increase. We're going to have a rapid pulse, increased sweating. And then instead of like a huge goiter, it may just be like a big nodule or something that's on either side of the neck. The treatment, of course, is surgery, but you can also use medication. Okay, we're going to stop right there temporarily. Okay, sorry for the short stop. We're going to pick up on your PowerPoint with Graves' disease. And I believe, let me see what page we're on here. I think I've lost my page again. But anyway, wherever Graves' disease is, I'm not sure where it is in your text, but that's where we're picking up anyway. So, when a goiter develops, you can get Graves' disease like occasionally, and this is when the whole gland is involved. With Graves' disease, you won't really have any nodules on the thyroid. It'll just be an extremely large goiter. And sometimes it's not even large. Sometimes it may just, be a regular size and you not know. But this causes it causes hyperthyroidism, and this is more common in women, and usually in the younger generations. So there is a look with Graves' disease that people have, and usually the facial expression on women with Graves' disease is very strained looking, intense. There's a stare in the eyes, and the eyeballs will protrude outward, and that's called exophthalmos, and this is caused by edema in the tissue behind the eyes. Excuse me. So that's what a patient with Graves' disease will look like. And occasionally it can get really bad to where the eyelids won't close for the patient. So, what we're going to do for this patient, is we're going to give them thyroxine or something to, help the thyroxine in the blood to help with digestion and things like that. Occasionally the patient will have an increased heart rate, and so we can give them like an antiarrhythmic to help with their heart rate to slow it down. Usually we can give them something like Valium and Xanax, because a lot of times they're very anxious and on edge, or very excitable, extremely nervous, and they may even have difficulty sleeping. So a lot of the treatment for this is going to be symptomatic, because we're just having to treat the symptoms. Another symptom of Graves' disease is excessive sweating. So the skin will always be very moist in nature, and usually they'll have an extreme thirst as well. I'm so sorry. Ugh. Let's see. Let's go on to treatment of Graves' disease. You can remove the thyroid gland. If the gland is removed, the patient's going to obviously have to take hormonal supplements. And you can do partial removal of the gland, which is a little bit better. and because it still allows the other side to secrete hormones. If you look at figure 12.9, that is a person with a severe goiter. Okay, let's try this again and maybe I won't have a coughing attack. So tests that you can do to determine Graves' disease are your thyroid test, your T3, your T4, and then of course your TSH. Alright, let's look at your 2 adrenal glands. And we're on page 315. I finally found my spot. You have 1 adrenal gland above each kidney, and of course you have 2 kidneys, so you're going to have 2 adrenal glands. Each gland is composed of 2 parts. You have your adrenal cortex and then your adrenal medulla. And if you look at figure 12.10 in your book, it shows you the right and left kidney, and then that little spongy part above each kidney is the actual adrenal gland. So the adrenal cortex, a part of the adrenal gland, is going to distribute a lot of hormones in the body. And we have your potassium. The mineralocorticoid, I believe that's how you say that, is secreted by the adrenal cortex. Okay. Also aldosterone, which is going to regulate your sodium and potassium. Your glucocorticoid hormone is going to be secreted, and this is going to regulate carbs in the body. The adrenal cortex also secretes the sex hormone, androgens, estrogens, and progesterone. And this is where a lot of people, when they're born, if they're female, they're born female, but they may have, male characteristics, or, they want to be a male, or they think that they are a male. This is where that can happen to take place while they're forming, is in their adrenal cortex. And they can sometimes actually characteristics of the opposite sex. The inner portion of the adrenal medulla is going to secrete your epinephrine and your norepinephrine. So epinephrine is also called adrenaline, okay? And so this is going to be used for a variety of different reasons. When you use it in surgery, we usually use it to, like for minor skin surgeries, we may use it to slow down the bleeding. For if a person goes into cardiac arrest, we may use it to start the heart back again. And then, of course, you have the norepinephrine that the adrenal medulla secretes as well. Let's see. When you have hyperactivity of the adrenal cortex, this is usually will cause the gland to enlarge and possibly even form a tumor. And this can cause a disease like tuberculosis, a weird kind of tuberculosis. Some steroid hormones can put you more at risk to have this disease, or actually give you this disease, because it'll atrophy the kidneys and atrophy the glands. Hypoadrenalism, let's talk about that. This is also called Addison's disease, and this is when adrenal glands fail to produce corticosteroids, and hence we get Addison's disease. It will also not produce aldosterone, and it will not produce cortisol. So the cause of this is usually destruction or damage to the adrenal glands, and it can be caused from cancer, infection, chronic use of steroids, like prednisone. Bodybuilders that abuse steroids are usually may develop Addison's disease. And then a lot of times we just don't know what causes this. And so when that is the case, it's called idiopathic. When the patient has an aldosterone deficiency, this means that they're usually not able to retain salt and water. So they may have like increased urination, basically. So the kidneys are not really able to to break down any of the waste matter that goes through them, and so the patient will have frequent urination. It can cause dehydration a lot of times. It will cause, can even lead to shock actually. And I don't think your book tells you this, but it can also cause bladder infections as well, or kidney infections. If a patient has cortisol deficiency, this can lead to very low blood sugar, okay, and this can cause your protein and your carbs to not metabolize properly, and this will, of course, give you extreme fatigue. The pituitary gland also produces corticotroponin in response to a deficiency of corticosteroids, corticotropin, excuse me, not troponin, corticotropin. And this usually stimulates the adrenal gland, the production of melanin, which is what makes your skin its color. It's like a pigment, basically. So persons with Addison's disease may have dark pigments, across the skin in different places, or they may have like a yellowish brown discoloration in the skin. And that's not everywhere. It could just be in patches. Addison's disease can be life-threatening and has to be treated with corticosteroid replacement. These can usually be injectable cortisol treatment. These can also be injected, like your cortisol. If you have a cortisol deficiency, that can be injected as well. Then we can start giving oral medicines after we get it under control. Okay, overactivity of the adrenal cortex is called hyperadrenalism, and this can cause Cushing's syndrome, Conn syndrome, adrenogenital syndrome, and pheochromocytoma. It's a big word, but those are some of the diseases and conditions that overactivity of the adrenal cortex can cause. So we're going to begin by looking at Cushing's syndrome. And that is, I think, we're on page 317, I believe. Cushing's syndrome. This is when you have an excess of glucocorticoid hormones. Okay, so signs and symptoms of this is going to be hyperglycemia or high blood sugar. And this is also called adrenal diabetes when you have high blood sugar with Cushing's syndrome. Can also cause a mobilization of lipids, and so instead of lipids being dispersed or fat being dispersed, throughout the body, it may just be dispersed right in here in the trunk area. Okay, and so this can also cause like a hump right here, and your PowerPoint says a buffalo hump. And it may not be extremely visible, or it may appear that the patient is, kind of slumped like this, but that is one of the big symptoms too. And then the arms and legs may be very skinny, but the patient just may be very round right in here, and then have the hump on the back. So other things it can cause is water retention, and this can cause high blood pressure. Then it can also cause fatty plaques to build up in the arteries, and this can, of course, put you more at risk for a heart attack and things of that nature. Signs and symptoms of this, besides the signs that we just went over, but symptoms, the patient may complain of muscle weakness or fatigue, kind of feeling like fluish sort of, easily bruisable, striae or stretch marks from weight gain, poor wound healing, because like I said, we do have an issue with sugar, and so that can cause the wounds not to heal very well, increased susceptibility to infections, and then the bones are going to be more likely to fracture, especially in the rib and backbone area. Treatment is going to be the surgical removal of your enlarged glands, or a removal of a tumor that can correct this condition. And then, of course, we're going to have to do hormonal therapy, either replacement or some other type of hormone to, lower the amount of hormone that you're producing. So if you look at figure 1211, this is a person before they were treated with Cushing syndrome and then after they received treatment. So you can definitely see that this patient, there's a vast difference in size. Okay, let's look at adrenogenital syndrome. It's one of the ones that we mentioned. This is when we have excessive androgen production in a woman, and it can cause the woman to take on masculine features. So we can have hirsutism, which is like hair that develops on the face, and excessive hair everywhere. The hairline may start receding, like in balding. The breasts may diminish. The clitoris may enlarge and almost start looking like a projection. Ovulation and menstruation will stop. And so this is usually due to some kind of tumor or something like that in the ovaries. If we have pheochromocytoma, this is a very rare tumor, but it can happen. And it happens in the adrenal medulla, and it causes overproduction of epinephrine and norepinephrine. So this can occur pretty much in men or women. It occurs, between 30 and 60, so about, a fourth of your life on to about, halfway through. Symptoms, we're going to have heart palpitations with this, increased blood pressure, rapid heart rate, chest pain, etc., etc. Treatment, we're going to do surgical removal of the tumor if we can, and then we can use medications to try to control the symptoms. And sometimes the physician may even give the patient medicines before their surgery to try to control the symptoms. Now, let's look at the parathyroid glands. And this is on page 318. The parathyroid glands are 4 tiny little glands, and they're on the dorsal surface of the thyroid gland. So you have the thyroid, and then right above it on the dorsal surface is the parathyroid. And this is also called the PTH, parathyroid hormone. And this is going to regulate the amount of calcium in the blood. So if we have, if calcium starts falling way, way low in the blood, this is going to kind of stimulate like an early onset of osteoporosis or other bone diseases such as that. If you look at figure 1212, this shows you where your parathyroids are. Let's see. Let's go on and talk about the diseases, and we're going to look at hypoparathyroidism first. And so this is going to be secreting lower amounts of calcium. The main symptom you're going to have here is tetany, which is like a sustained muscular contraction. Basically, you may have the patient may stay tensed up for long periods of time. So the muscles of the hands and feet contract in a characteristic fashion, and it may stay like that, or it may do it repeatedly so many times a day. It just, it all depends on the patient. The laryngeal muscles are very susceptible to these spasms as well, which is in the throat, and they can obstruct their respiratory tract, and may even think the patient is having an asthma attack, but they actually have hypoparathyroidism. So you have to be extremely careful with that. The low level of calcium in the blood is called hypocalcemia, hypo meaning low, and so this makes the nervous system just go crazy. I mean, it's like ADHD nervous system, basically. So when that happens, all your skeletal muscles are overstimulated, and this causes the person to contract like that. And so what we can do is give the patient calcium and also vitamin D, because vitamin D is also helpful to, in turn, produce more calcium. And this is going to help absorb the calcium from the GI tract, and it'll eventually correct the condition. The opposite of this condition is called hyperparathyroidism, and that's when we have too much calcium in the blood. And so the parathyroid gland is secreting too much calcium or producing too much calcium. So this is called hypercalcemia, okay? And basically what we do is, when this happens, we have we're going to lose calcium, but actually, because the bones are going to keep reabsorbing calcium. And so basically, we're not going to have circulating calcium in our blood because our bones just keep reabsorbing it. And as they reabsorb, they're going to get very large and thick and spongy in texture. And so this can cause deformity. It can cause an easy fracture. We can also have tumors that are on our bones, that can develop. And so you have to be very careful with that. Excessive calcium can also cause kidney stones. That's one of the main causes of kidney stones, as you learned previously, is increased calcium in the body. And then calcium, when it deposits in the blood vessels, and sometimes it will lodge, especially if you already have a fatty, plaque buildup. If calcium lodges, it can actually make the artery very hard and cause a condition called arteriosclerosis, which is hardening of the artery. If you look at figure 12-13, this shows a person's hand that has tetany, which is the hypoparathyroidism, and you can see the muscle contracture, and they may stay like this for a while, or they may just all of a sudden start jerking in short little bursts. So let's see. The symptoms of this is we're going to have bone pain, depression of the nervous system, muscle weakness. The heart muscle will be affected, especially if calcium starts depositing in your arteries. That in turn is going to make the pulse slow down. It's going to put you more at risk for stroke or heart attack. And then you're going to have GI disturbances too, like abdominal cramping or pain, vomiting, and even constipation. Sometimes you can have calcium that may form in the eye, and this can cause tearing of the really delicate tissue in the eye. And it can also cause your eye to tear very rapidly as well, too. Let's see. Let's keep going here. Let's start looking at the pancreas on page 320. The pancreas is a very important organ, and this is along the lower curvature of the stomach, and it's the only organ in the body that is an exocrine gland and an endocrine gland. So it will take in hormones from other places, and it will excrete hormones. So the exocrine part, which means excreting, is going to be when the pancreas releases those digestive enzymes like the chyme and others like that. That's considered an exocrine function. And then the endocrine function has several parts in it. We have the pancreas, of course, has the islets of Langerhans, and these are what's going to be producing your insulin and your glucagon, okay? And so patients that are diabetic are going to have a malfunctioning islet of Langerhans. Insulin, of course, is something that we have to live to, help maintain the body's homeostasis. And when we have a loss of insulin, we have diabetes mellitus. And the loss of insulin is going to make our blood sugar go through the roof. And so we have to give ourselves insulin. So this diabetes mellitus again. So the patient may take something like glucophage or Actos or something like that for the pancreas to secrete insulin. And then sometimes we have to do a insulin pump or just insulin injections. And then overproduction of insulin is called hypoglycemia, because it's going to produce too much insulin and in turn make our blood sugar really, really low. And so when that happens, usually we need to eat something sugary, preferably, or carbs. The patient may say that they feel very faint and start feeling, the room spinning, and usually it's just because they have low blood sugar. And so diabetic patients often have to snack frequently in order for that not to happen. Let's go on to glucagon. Let's talk about glucagon. This is secreted by the alpha cells that are in the islet of Langerhans. And basically what happens is when the blood glucose of your body falls way below what it's supposed to be, glucagon is released, and glucagon will circulate to the liver, and it'll stimulate the release of glucose from the liver as well. And so glucagon is essentially the same thing as glucose, but glucagon is like your backup, and then it can be a deadly matter if your blood sugar goes too far below normal. And then that takes us into talking about diabetes mellitus. There is several different types of diabetes, and we could have a whole class just on diabetes because there's so much information. But you have different types, type 1, and then you have type 2. Type 1 diabetes is usually, you're going to see a lot in children. It may also be called juvenile diabetes. And this is when the Langerhans cells get destroyed, and the patient can't produce enough insulin on their own. So they have to take insulin injections. So again, this usually starts at childhood. However, there are some cases that start after childhood. And this is called insulin-dependent diabetes mellitus. Okay. Then type 2 is your most common, and this is where the person makes a sufficient amount of insulin, but it doesn't really help the body. It's not secreting. It's making it, but not secreting, and it's not, helping to bring down the blood sugar. So these patients may not take insulin all the time. They may take a medication to make the pancreas secrete the insulin. And then some of them do have to take insulin. It just depends. But this is called non-insulin dependent diabetes mellitus. Okay, so they're pretty common. Both of these are very common, and they're pretty similar. And this can be also treated with diet, medications, exercise, all kind of things. So symptoms of diabetes mellitus, either type, you're going to have polyuria, which is increased urination, polydipsia, extreme thirst. You may have wounds that aren't able to heal very well. You may see glucose secreted into the urine, and when that happens, that's called glycosuria, and that is a medical emergency because the patient is basically knocking on death's door when that happens. You don't ever want glucose to pass the renal threshold. With this, cells really like to metabolize glucose, but when glucose is not there to metabolize, it will metabolize the fat first, and then the protein last. And so when this happens, the insulin action just doesn't work as it should be. Let's see. And this can cause ketones to appear in the urine as well. Ketones are basically from fatty substances when you metabolize what you're not supposed to metabolize basically. Other symptoms you're going to have, the normal pH in the urine is about 7.35 to 7.45. And actually, a lot of times we actually prefer it to be 6. And so their pH is going to be slightly, theirs should be in that range. Okay. We don't want them to be below 6.9 and or 7.0 basically. But in normal patients, we usually say that we like the pH to be about 6. That's exactly where we like it. But in diabetic patients, no, we want them to be slightly on the alkaline side. Weight loss, fatigue is going to be a big thing. Just no energy basically. So let's keep going and talk about complications that can happen from diabetes mellitus. We can have atherosclerosis, which is the fatty plaque buildup in the arteries, and that can cause wound healing not to occur or be very slow process. We can have a heart attack if we have a blockage of the coronary arteries. We can have high cholesterol, so all of these are big complications. We can have strokes because we're going to be more at risk for blood clots, basically, or what we call thrombosis, and then a blood clot, when it detaches, it's called an embolus, and when it detaches, that's when it gets very dangerous. It can travel to the lungs, cause a pulmonary embolus, travel up the carotid artery, and cause a stroke. So there's several things that can happen here. Can also cause an occlusion of a vein that feeds, like the femoral artery or something, to where we start having no circulation in our legs, or it could be arms too. And then we usually have to have it amputated, or we're going to get gangrene in that area. So it can weaken circulation. We can have diabetic retinopathy, which is it can result in blindness if it's not treated. They basically the little blood vessels in the retina can rupture and cause this. The nervous system is going to cause tingling sensation in the extremities, or loss of feeling, or sometimes even a paralysis. And then we can also have kidney failure with diabetes as well. So treatment of diabetes mellitus, we're going to have low-fat diet, low-sugar diet. So basically diabetic diet is what we call it. Good exercise, take your insulin if needed, medications, of course. And we want to make sure the patient is not in any kind of emotional distress, because this can cause ill effects on the body, and so we want to make sure we regulate that. You want to monitor blood sugar levels. This is usually why all these poor diabetic patients have little holes all in their fingers, because they're having to take their blood sugar daily, and several times a day actually. Diabetic coma. This is one complication that can happen. And this is basically when blood sugar gets too high, or failure to take your insulin, or you're not, following your diabetic diet like you should, and this can lead you into a coma. Symptoms of diabetic coma, or the onset of diabetic coma, it's going to be a deep labor breathing, acidosis, which means like your pH level in your urine, if it goes below that 7.0. That's called ketoacidosis, diabetic ketoacidosis, and it will cause a coma. When you have glucose that goes into the urine past the renal threshold, that's called diabetic ketoacidosis. The patient may have a fruity smell of their breath. Their urine may even smell fruity. They may have a flushed look, like they're hot, but they'll be very dry skinned. So those are some of your warning signs of coma. Treatment of diabetic coma is urgent replacement of fluids. You want to correct the dehydration. You want to give insulin intravenously so it acts immediately to bring down the blood sugar, and hopefully the patient will come out of the coma. The other side of that is insulin shock, and this is when we have too much insulin in the body. So, the pancreas just keeps secreting, or excreting, insulin. And insulin is just taking over and lowering the blood sugar way too much. And so we could, not be eating enough. We could be exercising too much to cause this to happen. So warning signs of insulin shock are going to be lightheadedness, faintness, trembles, perspiration. And to help this, we want to try to take any kind of carbs or sugar or something. And if that doesn't help, then definitely go straight to the emergency room. Insulin shock, if there's no treatment, it goes unnoticed, and we just kind of live with the symptoms, then you will go into a coma with that. Let's see, to treat insulin shock, we're usually going to give IV glucose immediately, and then we're going to give epinephrine to try to increase the heart rate, and in turn that will actually raise the blood sugar in the blood. So let's look for common tests for diabetes mellitus on page 325, and we're almost done with this chapter. One of the big things that we do with diabetic patients is we do urine tests. So we want to test for ketones in the urine, we want to check the pH in the urine, and we want to make sure no glucose is being secreted into the urine, or excreted into the urine. You also can to test for diabetes, you can do a fasting blood glucose, or what we call like a 2-hour postprandial, just to see how well your body is absorbing blood sugar or absorbing sugar and producing insulin. And that basically tells us what type of diabetes you have, or if you have diabetes. And so basically the main thing that we do to test if a patient has diabetes is we're going to do fasting blood sugar. So they don't have anything to eat or drink after midnight the night before. We'll have their blood work done, and then sometimes we'll go and send them to eat something and then take their blood sugar right after eating, and then the 2-hour postprandial, 2 hours later, take their blood sugar again and see if it's still high or if it's extremely low or if it's just right. And it should be just right. We want to make sure your body is metabolizing correctly. That's also called glucose tolerance test too, by the way. Let me see. Every time the patient may come in, we may do a hemoglobin A1C. That's what that's called. And that just checks like a summary or an average that the patient's blood sugars have been running over the past 3 to 6 months, depending on what type of machine that you're having, that you have in your office or your hospital, wherever you work. But usually we don't want the hemoglobin A1C to go above 6. We want it to be 6 or under. So that's another test that can be done. Let's look at table 12.2. This is some warning signs of diabetes, and we've kind of already talked about that, but I do want you to look over that because that will probably be on the test. And then let's look at abnormalities in sex hormones. When our body doesn't secrete the correct amount of sex hormones, or they secrete too much of the opposite sex hormone. So the gonads, which are ovaries and testes, I know a lot of people think that gonads are just in males, but it's ovaries and testes are both called gonads. These are endocrine glands as well, and this is what the ovaries obviously produce the egg, or what we call the ovum, and then the testes are going to produce the sperm, or the spermatozoa that we call it as well. And so females are going to produce estrogen, males will produce testosterone, and females can produce testosterone as well. But what happens sometimes is these get out of whack and we produce too much of what we're supposed to produce, or sometimes we can produce the opposite of what we're supposed to produce. So this can happen and cause, the excessive hair growth in females, or males. They may actually start growing breasts. They may actually, their voice will start changing. So that's what can happen when we have the error with sex hormones. Let's see. Changes in endocrine functions with age. As we age, everything decreases, and so your growth hormone is going to decrease, and that's why we stop growing after a certain age. So pretty much with men after 30, we're going to have a decrease in lean body mass, and we're going to have more of an increase in lipid production. Increased body fat is going to, of course, put you more at risk for diabetes, heart disease, and things of that nature. And then if we have a decrease in our thyroid function, which is the T3 or T4, this can result in slower metabolism. And I know women especially, we always say, yeah, my metabolism is slowing down because we may diet and exercise so strongly for 3 weeks and end up not losing anything, or we may even gain something as well. And so it's just because as we age, everything slows down, metabolism, everything. So that's why that can happen. As we age too, your body is less capable of dealing with stress. And as I've said before, stress will affect everything in your body. It can make hormones not secrete. It can make them over secrete. It can cause everything pretty much. And so this can put damage on your body. It can increase your blood pressure. It can dehydrate you. It can just have you excessively fatigued, and so it can also affect your potassium levels as well. And anyway, so that's what stress can do as you age too. And the more you stress, the more effect it's going to have on your body as you get older. The pancreas with age will stop secreting insulin as well as it should. That's why you see a lot of elderly people are more common to have diabetes, because it doesn't produce until they're a little older. And then of course androgen and estrogen drops with age. Your diagnostic procedures for any endocrine is going to be your TSH, your T3, your T4. For all your thyroid disorders. For your pituitary disorders, you want to do growth hormones. For your parathyroid disorders, you want to do your calcium and your PTH. Your adrenal disorders, you want to look at cortisol. And then, of course, you can have the diabetic type of conditions, and you want to check your glucose tolerance test, glucose levels, hemoglobin A1C. Then we can also do a urine specimen, a CAT scan, and an ultrasound, and there's many others too that the book just didn't list. So we will stop there for today.